Okay, let's get started. I'm going to throw it over to Dr. Kathiresan.
Hi, everybody. I'm Anupama Kathiresan. I am one of the Kindbody fertility specialists in the Los Angeles area. So I'm happy to be here to do some basic fertility 101 education and also answer some questions. You can go to the next slide. So Kindbody, one of our important missions and passions is to bring high quality fertility care and make that care accessible to patients. And we provide full service fertility as well as gynecologic care. So we're very passionate about this mission. And as I mentioned, we provide full service fertility and gynecologic care. So some of the things that we offer are your initial assessment. That fertility assessment could be in person, it could be virtual. For patients that are considering fertility preservation, we offer egg freezing and embryo freezing. For patients trying to conceive, fertility treatments like IUI, IVF, for those needing third-party services, for example, donor egg or donor sperm or a gestational carrier, all things that we're able to help with. In addition, we offer holistic medicine, for example, nutrition, wellness. We have therapists that help with the mental health aspects of going through fertility treatment. So we really try and address all aspects of fertility. And then in addition to that, gynecologic care, we offer the well women's visit, contraception, so kind of your full spectrum gynecologic services as well. So again, we're on a mission to bring fertility, high quality fertility care to patients. And one of the important things to consider is time, and time is a factor when we're talking about fertility. You can go to the next slide. So one of the things that we're taught in our youth is, or kind of the main thing we're taught about in like sex ed classes, is how to prevent pregnancy. And then when it comes to later on in life, when we're actually trying to conceive, a lot of the time we don't have that basic fertility knowledge and education in order to help us to try and conceive. So we're hopefully helping to increase fertility education awareness through talks like this. And so we're hoping to kind of minimize that disconnect. So one of the most important factors to consider when it comes to fertility is age. Age is the biggest prognostic factor when it comes to success rates with conceiving and fertility treatments. And so what happens with advancing age is two things. There's a decline in both egg number and egg quality. And so one of the things that is not really known is when we're actually still in utero in our mom's belly is when we have the most number of eggs that we will ever have, and that's around 6 to 7 million. By the time that we are born, that number has already declined to 1 to 2 million. By the time we reach puberty, it's about 300,000. And then when we reach our 40s, it's around 25,000 or so. And so there's a rapid kind of decline throughout our life. And then in addition, each month we don't lose one egg, but we lose a whole set of eggs. So that's something also that's important to know and to keep in mind. And so you'll hear a lot of people talking about the age of 35 and there being a rapid decline in terms of fertility at the age of 35. And in reality, it's not necessarily a switch that turns on and off at that age that, all of a sudden that there's a dramatic decline, because that decline is gradual. As we mentioned, there's, you're born with a certain number and that will decline over time. But we do start to get concerned in our early 30s is when it kind of starts to decline a little bit more rapidly, and then at the age of 35. So it's important to be aware of this. And then in addition, 1 out of 10 women could experience premature low ovarian reserve even under the age of 35. So it's a good idea to, if you're thinking about, perhaps egg freezing or conceiving in the future, to see where your ovarian reserve assessment is, because at least if you get an evaluation, see where your numbers are, there's reassurance in the next steps of the journey in terms of trying after. So as in addition to there being a decline in egg number, there's also a decline in egg quality. And when an egg is made, there are division processes that the chromosomes will go through, and that will result in a normal number of chromosomes in the egg. Now, as we get older, those division processes become more inefficient and they make more errors. And so that results in an abnormal number of chromosomes in the egg. And so when the egg has an abnormal number of chromosomes, the patient's going to be more at risk for miscarriage and also passing a genetic abnormality down to the offspring, for example, Down syndrome. So it's always good, I think, in general, to be proactive and to get as much information as you can on the front end, as opposed to letting the passage of time have an impact and then perhaps in the future looking back with regret. So it's great that all of you are here and interested in this topic and being proactive with considering learning more about your fertility. So when it comes to the fertile window, the first thing, or when you're most fertile, so that's something that we call the fertile window. So the first thing to keep in mind that's important is that a patient needs to have regular cycles, and regular cycles come usually with a frequency of every 25 to 35 days. So the approximate time of ovulation is going to be 14 days prior to a woman's next period. So for example, if a woman has a 28-day cycle, they should approximately ovulate around cycle day 14, so 28 minus 14. Whereas if a woman has a 35-day cycle, they should ovulate approximately around cycle day 21, so 35 minus 14 again. So it's important to know what your cycle length is and then when the approximate time of ovulation is. And then that fertile window is going to be that 5-day interval prior to ovulation. So that's going to be your most fertile time. And so having intercourse every day or every other day during the fertile window is usually sufficient. So when we're going through the fertility journey and fertility treatment, it's always important to try and be as healthy as we can. So healthy lifestyle, including diet and exercise. Usually we recommend the Mediterranean diet, and then exercise, trying to do what you can to stay healthy. In terms of family history, it's important to assess this with your provider if there is a history of, let's say, several cancers in the family or genetic conditions, to make sure that we're considering that in your fertility journey. And the last thing, also considering mental health. Going through the fertility journey as well as treatments can be stressful. So I always try and recommend, whatever we can to do to decrease that stress. Try and I tell patients to try and indulge in the things that bring you joy and self-care and help take your mind off the process. And that can be different outlets for different patients. For example, acupuncture, meditation, Netflix series, taking walks with your partner. So, whatever outlet that helps to put you in a good headspace, I think is important when going through the journey. The definition of infertility. So first, assuming that a couple has regular cycles and there's no red flags, for example, a known history of endometriosis or something along those lines. But otherwise, the definition of infertility is if you're under the age of 35, trying for 1 year and not being successful, or if you're between the ages of 35 and 39 and if you've tried for 6 months and if you're unsuccessful. So about 1 in 8 couples do experience infertility, so it's fairly common. It's important to also know that a third of the time it could be due to the female, but a third of the time it could be due to the male, and a third of the time it could be both that are potentially contributing. So it's important to evaluate both partners, both the man and the woman, when getting the workup for infertility. At the end of the day, there's no magic formula. Everyone is different. And so to really get a good idea of where your fertility stands, it's important to get evaluated, to get more information and to see, where your fertility lies. So a common question that we get is, what do we do at the initial consultation? So that involves meeting with your fertility specialist or fertility provider and having a one-on-one consultation with them. And at that visit, we'll go over your medical problems, we'll go over your surgical history, medications, allergies, we'll go over family history if there's any cancers that run in the family or genetic conditions, and also if there's any premature menopause that might be running in the family. And then another important point that we discuss are, what are your family building goals? How many kids are you hoping to have, and when are you hoping to have them? And that really helps us to determine what path may be right for you when we consider your overall family building goals. And then based on the history, as well as your family building goals, we'll develop a personalized plan, what workup we'll need to do from that step on. Next slide. And then in that initial visit, we'll also do a transvaginal ultrasound. And in that ultrasound, we're looking at pelvic anatomy, making sure if there's any fibroids or any abnormalities when it comes to the pelvic anatomy, as well as looking at a follicle count. And that follicle count gives us an idea of egg number. So that's something that is important for us to assess with the ultrasound. And then the last thing is doing a blood test called an AMH. This stands for anti-Mullerian hormone. And this also will tell us about egg number. Both the follicle count and AMH kind of help us correlate what might be left in terms of egg numbers in the ovarian reserve. And they also help us with later on with treatments, expectations with treatments and medication dosages and this type of thing. As I mentioned, so the follicle count and the AMH will tell us more about egg number, not necessarily egg quality. Quality is not something that we can directly test for. It's going to be more related to the woman's age. But having said that, the AMH and the follicle count do give us some information in terms of egg number, as well as how they may respond to treatment and helping us with dose medications. So there are several options in terms of fertility treatments, depending on what your goals are. So if you're hoping to freeze eggs or freeze embryos because you're interested in fertility preservation, those are options that we offer. If you're trying to conceive and having difficulty, options might be IUI or IVF, or if a patient or couple are needing donor egg or donor sperm or gestational carrier, all of these are options that we provide depending on what your goals are. What is egg freezing? So egg freezing is the process of going through IVF, or at least the initial part of IVF, and freezing eggs in time in hopes that we can use those eggs later on in the future to increase our chances of having children in the future. And these are really important questions to consider when considering, fertility treatments and egg freezing. So one is, how old are you? Because that really will factor into treatment sometimes and what we would recommend. And then in addition, how many kids are you hoping to have? When you envision your future family, how many kids do you see? And then when do you want to have those kids? At what age do you want to have your first kid? At what age do you want to have your last kid? And looking at your current ovarian reserve, all of these things will help us guide you to what fertility treatments we would recommend. So it's important to not necessarily consider just baby number one, which patients often do, but also just taking a step back and looking at what are your overall family building goals, so we can also consider baby number two and baby number three later on down the line. So what happens in a normal cycle when a patient is not going through treatment is that your eggs, I describe it like your eggs are locked away in a vault and we can't see them. And each month a certain number are released and become visible. And that's that follicle count, that antral follicle count that we assess on ultrasound. So each month, one of those follicles will grow to have a mature egg within it and will eventually ovulate, and the remaining eggs die off. And the next month, another set of follicles will be recruited. So when patients are considering going through egg freezing, a common question that we get is, will this impact future fertility? And what we do with the process of egg freezing is that instead of that one egg growing, we're trying to give medications in hopes that all of the eggs grow. So the only difference between a normal cycle and going through an egg freezing cycle is we're trying to get all those eggs to grow that would have otherwise died off. So this does not impact future cycles. Okay. And so the way that a normal cycle again works is there's communication between the brain and the ovaries. And so what happens is the brain will produce FSH, which stands for follicle stimulating hormone, and that will travel through the bloodstream to the ovary and stimulate the ovary to grow that one follicle a month. So what we're doing with the egg freezing cycle and with IVF is we're giving FSH through the injections. So we're giving medications that are similar to what the brain would normally make anyway. But instead of growing one follicle that month, we're trying to give more FSH so all of the follicles will grow that month. So, and again, those eggs would have otherwise died off. So we're just trying to be opportunistic, and in the sense that instead of them dying off, we're trying to get them all to grow so we can retrieve all of those mature eggs so that we can have them for the future. So the hormones usually last anywhere from 8 to 12 days. It just depends on the woman and her response. And then we'll be monitoring patients when they're on the injections with blood work and ultrasound and seeing how that patient is responding, and then adjust medications as needed when they're going through the stimulation part of the process. And so this is a calendar just trying to outline a timeline, but essentially the time frame for the injections, as I mentioned, is about 8 to 12 days. And then once that 8 to 12 day time frame of injections is completed, the egg retrieval will fall 36 hours after the medication we call a trigger. But essentially, it's overall about a 2-week process. So patients often think it can be longer, but it's actually only 2 weeks of the injection and monitoring time. So it's not that long. The egg retrieval. So that is a minor surgical procedure that we do to remove the eggs. And it is only about 10 to 15 minutes, and it is done with anesthesia. So you're in a deep sleep, you won't feel anything as we're doing the procedure. And it's done with ultrasound guidance, and we're essentially just advancing a needle through the vaginal wall into the ovary. And then we step on a pedal, and that activates a vacuum suction mechanism. So we're essentially removing the fluid and the eggs with that mechanism. So it's, and the recovery is about 24 hours. So it's overall a very minor procedure. Just to touch on the difference between egg and embryo freezing. So the advantage of freezing eggs, let's say a woman is single, wanting to consider preserving her fertility for the future, so she can undergo this process and freeze eggs. And so the advantage there being that she has the reproductive freedom later on in life to choose the sperm. And then once she meets her future partner, can come back, and then we can create embryos from the eggs that were previously frozen. So the main advantage being the ability to choose a sperm later on in life, versus the embryos, where an embryo is after the egg and sperm have come together. And the advantage of embryos is that we're able to genetically test the embryos. So we know with a little bit more certainty after that process what we actually have in terms of genetically normal embryos. But the disadvantage is that, depending on how you look at it, that we have committed ourselves to that sperm. And both are, in terms of survival rate, they are very similar in terms of the egg and embryo surviving the freeze-thaw process. So that alone should not necessarily dictate if a woman chooses to undergo egg freezing versus embryo freezing. But it's more related to, if the woman wants to choose a sperm later on in life, or if she would want to know the genetics, in which case the embryo would be where that information could be obtained. So after going through the process of freezing eggs or freezing embryos, let's say a patient, a few years later is ready to consider starting their family. you don't necessarily, depending on your age and, if cycles are regular and these type of factors, but assuming that the woman's under the age of 40 and cycles are regular, you don't necessarily need to come back and use them right away when you're ready to start your family. You could consider trying on your own if you're under the age of 35 for up to a year, if you're between the ages of 35 and 39 for up to 6 months. So it is an option to try on your own prior to coming and using, but if unsuccessful, then you could always come back and then we can consider fertility treatments and thawing the eggs or embryos and next steps from there. So IVF is similar to the egg freezing process. It's just a different endpoint. So with the egg freezing process, you take the injections, you go through the egg retrieval, and then we freeze the mature eggs. But with IVF, we would not freeze the mature eggs. Instead, we'd put the egg and sperm together on the day of the egg retrieval, and then we would have an embryo. We allow the embryo to grow for a period of 5 to 7 days in the lab until it becomes what's called a blastocyst. And that's when we have the option to genetically test the embryo, and then we can freeze the embryo and wait for the genetic testing results. So both are similar processes. It's just a different endpoint with where the stopping point is. So with egg freezing, freezing when we get to the mature eggs, but with IVF, we allow the creation of the embryos afterwards. So again, they're different paths to parenthood. Doesn't necessarily mean, a lot of people think fertility treatment and think they have to do IVF. There are different options. Our goal is to, take your history, find out what your goals are, and then review all the options and success rates, and then figure out what feels right for you. And so that can be different for different patients and different couples. And again, treatment options include IUI, IVF, sometimes just ovulation induction. Oh, something happened. Sorry with my screen. Okay, sorry about that. And also, if patients are considering third-party fertility treatments, such as donor egg, donor sperm, or gestational carriers. So these are all options that we would provide. So next step is really, knowledge is power. So I always encourage patients, take advantage of what knowledge you can gather and obtain. Be proactive, learn about all your options so that you can make the best decisions for you, as opposed to, again, letting, the passage of time perhaps change things and looking back with regret. So I encourage you to just, learn as much as you can and learn about all your options so you can make the best decisions for you. So as we mentioned, we have several Kindbody fertility clinics throughout the country, and we're continually growing. I think we're at 23 now. I may be incorrect, but there's several clinics. Hopefully, there'll be one popping up nearby you, if there isn't already. And for joining us today, we're offering this discount code as well. So feel free to check out, it looks like the code is JUL22. And so check out these discounts when it comes to your initial assessment, so your fertility assessment, and also treatments for egg freezing and IVF and IUI cycles. All right, I think that is it. I will hand it off to questions.
Thank you, Dr. Kathiresan. Here we go. I'm gonna help you, and we got tons and tons of questions, of course. So this is an Ask Me Anything. We're going to take the second half of the webinar to do the Ask Me Anything. We're going to try and get to as many questions as we possibly can. But again, we only have a set amount of time. So if your question doesn't get answered, you can always feel free to reach out to Kindbody via DM on Instagram, and we will get those questions answered for you. And again, this is recorded, and we're going to be sending an email tomorrow with recording of this event, as well as the promo code and everything you need in there. If you would share it with anyone, you'll have that available to you. Okay, so let's get started. Great first question. It was touched on a little bit during the talk, but I think it's worth reiterating. So this came from Rebecca, Dr. Kathiresan. I have a low AMH level. If I take medications to stimulate ovulation or to freeze eggs, I Am I essentially lowering the chance of becoming pregnant naturally by retrieving some of the few eggs that I have?
So that's a great question. And no, you're not. By going through egg freezing or IVF, what happens is isolated to that cycle. So what would happen if you were not going through the treatment is those eggs would die off. So all we're doing with going through fertility treatments is giving you medications to grow all the eggs so that we can use them. And then the next cycle, another set of follicles come. So it does not impact future cycles or future fertility.
Great, thank you. Okay, here's another one. We got a couple questions about PCOS, so maybe it's worth going into a little bit in depth. So this question is, I have PCOS. How does that affect my egg count? If it does, also, can I still go for egg freezing and IVF later on? And I think it's worth just sort of broadening the question a little bit. How does PCOS affect fertility as a whole?
So PCOS is the condition where there is a disconnect in that communication between the brain and the ovaries. So what normally happens is the brain makes FSH that will travel through the bloodstream to the ovary to get the ovary to grow that one follicle a month. And so with PCOS, there's just a disconnect there. And often times patients just need some medications like Clomid or Letrozole or these type of medications just to help stimulate that ovary to grow the follicle once a month. It doesn't, typically patients with PCOS have a high AMH, not necessarily, but it's generally associated with that and a high follicle count. But the same things that we discussed in terms of the decline in egg number and egg quality as we get older also apply to PCOS. Just because they're not having regular cycles does not mean that decline is stalled. So these still, apply to women with PCOS or women that are on birth control pills. So, there's not necessarily an effect on the PCOS and that aspect of things, but it's just a matter of sometimes needing fertility treatments to help stimulate that process of ovulation. And then PCOS women can still undergo the process of IVF and egg freezing if they're interested in that.
Thank you. Okay, here's another one. And this is a topic that we don't talk about as much, but I think it's useful. Could you touch on ovulation induction? Would that be a good starting point for someone with irregular periods?
It can be. So it's good to start with the fertility assessment and, determine why might cycles be irregular first. So that can sometimes be due to uncontrolled thyroid or uncontrolled prolactin disorder, or let's say uncontrolled diabetes. And then also it could be due to PCOS, but also when we get older and our ovarian reserve decline, cycles start to also become irregular. So it's good to understand what the etiology of the irregular cycles could be. But assuming that it is more like a PCOS type patient, then yes, ovulation induction, kind of what I just described with taking Clomid and Letrozole, sometimes injections, basically help that process of ovulation to occur because of that disconnect between the brain and the ovaries.
Great, thank you. Another question that we get all the time, and I'm going to sort of break this up into two parts. We get asked all the time, is there any way to improve your egg quality or quantity? And is there any way to improve your AMH level through lifestyle, through anything? Is there any way to improve those things?
Yeah, I wish there was. Unfortunately, there's not a correlation with, being healthy and, having good ovarian reserve. So while we do encourage patients to be healthy with healthy lifestyle, diet, and exercise, that doesn't necessarily mean that improves egg quality. And unfortunately, again, because of that decline in egg number and egg quality as we get older, there's nothing to do that we can do to reverse that process. It's just a constant decline as we get older. There are some supplements, for example, CoQ10 and DHEA, that we sometimes recommend. These things are not going to necessarily dramatically change ovarian reserve. They can help a little bit. So whenever I have a concern for ovarian reserve, I usually do still recommend those supplements, but there's unfortunately no way to reverse that process.
Great. Okay, let's see. Let's pull one out here closer to the end. Okay, is there a minimum level of AMH required for successful IVF? Is there any minimum when you come in as a patient and you come in and take your AMH? Is there any level where we would not perform IVF on that patient?
That's a hard question. I would say that I don't necessarily have a cutoff, but I would counsel that patient in terms of what the risk could be with a low AMH prior to going through IVF or egg freezing. And so some of those risks would be not responding to the medications, perhaps not getting an egg at the time of egg retrieval, and not having it if the end goal is an embryo, not having a genetically normal embryo. So depending on how low the AMH is, I'll kind of, do my best to help guide the patient in terms of how real are these risks. But I wouldn't necessarily say a patient can go through the process. I just want them to be kind of well informed of what the risk would be.
Makes sense. Okay, here's a simple question we get asked all the time. Do you need to go off birth control to do egg freezing?
So I would usually, when you're getting the initial assessment, like your AMH and your follicle count, we can do that while you're on birth control. And there's not evidence necessarily to show that these values should be suppressed. Having said that, if I have a patient where, let's say, the AMH is lower than I would anticipate for her age, then yes, I might consider having the patient come off birth control for a few weeks and then rechecking it just to double check, is this in fact real in terms of their ovarian reserve numbers? And then in terms of going through the egg freezing process, yes, we do not want you on birth control. I usually would want patients to be off of it for like a month or so, just to help kind of the ovaries just be less suppressed right prior to doing the egg freezing cycle. And sometimes the protocol will involve birth control, sometimes it may not, but I usually would want them to be off of it for a few weeks before we proceed with the process.
Okay, thank you. And is there any way you can tell the egg quality upon retrieval?
We cannot. The only assessment that we theoretically have for quality is going to be when the embryo is created and we do the genetic testing. And so when we do the genetic testing, if we have, let's say, a higher proportion of genetically abnormal embryos than we anticipate, then that may be a reflection of that quality issue. But there's no other specific way to test for it. It's going to unfortunately just be more related to the woman's age and that factor.
Great. Here's a question we get asked all the time. For both preparing for an egg freezing cycle or even a frozen embryo transfer cycle, is there any impact that lifestyle factors can make on the success of those cycles? So for example, if someone is taking their injections for their egg freezing cycle, in the 10 to 14 days leading up, can they have a glass of wine? Can they exercise? Can they, what are the lifestyle changes that you recommend?
So I would always recommend a healthy lifestyle. So usually we recommend Mediterranean diet. In terms of exercise, it's okay to exercise in preparation, but we do not actually want you to exercise when you're on the injections. And I would even say until you get your next period. So that's essentially a month of not exercising. The reason is that when you're going through the process of IVF or egg freezing, you're growing multiple follicles. Your ovaries are getting bigger. And when your ovaries get bigger, they're at more risk of twisting on itself and cutting the blood flow supply off to the ovary. So that's the situation we do not want to be in. So we don't want any kind of exercise or motion, like intercourse, those type of things that might put the ovaries at risk for twisting on itself or ovarian torsion. In terms of the wine and definitely no smoking. Smoking has been shown to have an impact on ovarian reserve. For wine, we do say try to abstain from alcohol, but I really don't think like one glass of wine during the entire stimulation process would necessarily have an impact. But we just generally want patients to have that healthy lifestyle mentality when going through the treatment.
Great. Okay, here's an interesting question. If I go on a birth control pill that prevents ovulation, could that extend my months of fertility by not having those eggs released during the time that I'm on birth control?
So that's an excellent question. And unfortunately, it does not. So The decline in egg number and egg quality as we get older still occurs even if a woman has been on birth control. There's still the loss of eggs, each month that a woman would experience when she's off birth control. So there's still going to be that decline.
And sort of associated with that, is it possible to ovulate and not release any eggs?
So ovulation, the definition of ovulation is the release of the egg. So if you, let's say, are doing ovulation predictor kits, that's very reassuring that the process of ovulation should be occurring. So I guess I'm not quite understanding the question though.
Actually, I can clarify. Can you get a regular cycle? Can you get your period and not be releasing eggs?
Yeah, it's possible. But I would say having regular cycles is 95 to 97% reassuring and that ovulation is occurring. So yes, there's a small percentage chance that ovulation may not be occurring, but generally speaking, having regular cycles that come every 25 to 35 days in good frequency, then that's reassuring that ovulation is occurring.
Great. Okay, now I'm going to give you a two-parter because I'm not exactly sure. There was a question about the LGBTQ path and how that works. And so why don't we talk a little bit about same-sex female couples and same-sex male couples and how those two processes might work.
Yeah. So with same-sex female couples, I always encourage both partners getting evaluated because sometimes that can change our path. So, for example, if one partner is ready to pursue the treatment, but let's say the other partner has lower ovarian reserve, then we may kind of switch our plan and maybe have the other partner consider pursuing treatment. So it's always good to see where both partners are in terms of ovarian reserve. And then options could be just depending on the results of the fertility workup, maybe insemination with donor sperm. It could be also IVF with donor sperm, just kind of depends on the patient, their ovarian reserve, how they feel about success rates. And then there's the option of reciprocal IVF, where one patient can go through IVF and create the embryos and the other person can carry the pregnancy. So all of these are options. And then when it comes to same-sex male couples, so typically that would involve selection of an egg donor. And so that can be someone that goes through the process of IVF for them at that time, or it could be using frozen donor eggs. So women that have already frozen their eggs and they're already frozen and stored in an egg bank, and then you could select and thaw those eggs, and then putting the egg and sperm together, and then putting the embryo in a gestational carrier. So those are some of the options.
Lots of options for sure at Kindbody. Okay, here's an interesting question. Again, we get to ask this all the time. Are the success rates different for a fresh embryo transfer versus a frozen embryo transfer?
So there is a slightly higher success rate with frozen embryo transfers. And the thought for why that might be is when you go through a fresh IVF cycle, you're taking all the injections, the estrogen level is higher than it would be in a normal cycle. And so we wonder, does that higher estrogen level potentially have an impact on the uterus? And maybe that's why there's slightly lower success rates with a fresh transfer versus a frozen transfer. So I tend to lean more towards a frozen transfer because I'm always trying to fight for every percentage point that I can. And then in addition, the other advantage of a frozen embryo transfer is that you can do, if you're doing the genetic testing of the embryo, we need time for that result to come back. And so by freezing the embryo, that allows us the time to wait for the results and review if we have a genetically normal embryo. And then that can help us with decreasing the time to pregnancy if we do the genetic testing sometimes.
That's amazing. And what are some of the, can you go into the process of genetic testing a little bit, and why would that be something that it might be a reason that somebody would choose embryo banking over egg freezing if you are with the person that you'd like to have children with? What kind of benefits does that give you?
So freezing, doing the genetic testing is essentially once the embryo gets to the blastocyst stage, it differentiates into the future baby, which is called the inner cell mass, and then the outer cells of the embryo, which are called the trophectoderm, but it's the future placenta. So we're able to basically take a sampling of a few of the cells that would become the future placenta, the trophectoderm, and get the genetic makeup of the embryo. So we get the chromosome number, and we also get the sex. And there's 46 chromosomes, so it's a very thorough test. And then patients can know the gender, but they can also choose to not know the gender. And so going through this process compared to egg freezing, knowing the genetics helps us kind of know with more certainty what we have in terms of genetic normalcy at the end of the process. Each genetically normal embryo has typically a 60 to 70% chance of success. And so in addition, if a patient or a couple are trying to build their family and know how many girls and boys they want to have, and, you know, so all these things can kind of help with future family building by knowing all this information. Whereas with egg freezing, I wish there was a way that we could know the genetics of the egg, but unfortunately we do not. We would just freeze the mature eggs, and we wouldn't know about the genetics of the egg until we create embryos and genetically test them later on down the line.
Thank you so much. Okay, here's another question that we get asked a lot. Is the AMH test alone a pretty good indicator of fertility?
So it is not in the sense that, so it's not a predictor of pregnancy. Studies have tried to look at that and have not been able to show that. So, you know, often patients will ask me, does this mean I can't get pregnant? Not necessarily. But it is a helpful resource just to understand egg number and also expectations when we go through fertility treatments in terms of how many eggs we may get. So we use the AMH as well as the follicle count to kind of give patients a good expectation at the end of a treatment cycle, what to expect. And then it helps us with medication dosages, but it is not in and of itself a predictor of, you know, if a patient can conceive.
Thank you so much. Okay, I'm gonna give you a couple more. Okay, what do you recommend when you have PCOS? Pre-diabetic and also hypothyroid. Also, does taking medications affect when you do frozen embryo transfer? So,
sorry, I missed the beginning part. Yeah.
I'm going to separate it into a few questions.
Okay.
Does taking medications affect when you would do frozen embryo transfer?
Taking medications affect when I would do a frozen embryo transfer? I guess it depends on the medication.
Yeah, I guess it would depend on the medications. Maybe this person can clarify. If you just post it a little bit lower in the chat, we can get to that question. What are the best ways for someone to prepare for a frozen embryo transfer? Aside from the medications that they're going to take, how can they best increase their chances of success best?
Yeah. So I would, again, just generally speaking, recommend healthy lifestyle. So usually recommend the Mediterranean diet. As much as possible, trying to, you know, between healthy lifestyle, diet, and exercise, trying to achieve a healthy BMI. That's always good and helpful if it's possible. And then, you know, just trying to minimize alcohol, avoid smoking, no recreational drugs. And then after the transfer, we want you to treat yourself like you're pregnant in the sense of avoiding like raw meats, unpasteurized dairy products, and that type of thing. And also being on a prenatal vitamin.
Of course. And what, aside from prenatal vitamins, are there any other supplements you recommend? A few people asked about that for just overall health and fertility.
No, you know, I would say, you know, generally prenatal vitamin. If I have concern for ovarian reserve, then I would usually recommend CoQ10 and DHEA, but that would be going through the IVF portion of treatment, not at the transfer portion. So, because then we're past the ovarian reserve aspect of things. And then in PCOS patients, inositol, myo-inositol is something I will sometimes recommend in patients as well.
Great. Okay, a couple more. What are some common causes of miscarriage, and is there any way to prevent them?
The most common cause is going to be genetically abnormal offspring, so genetically abnormal embryo. And then other causes are going to be, like, for example, if a patient has a history of recurrent pregnancy loss, then we actually do more of a workup in that patient. And things we're going to look for are the genetics of both partners. So we look at the karyotype of the female and male partner, thought process being like sometimes there can be subtle abnormalities in their chromosome makeup, which don't necessarily present on them phenotypically, but when egg and sperm are made, those subtle chromosome abnormalities can show themselves in their egg and sperm. And there can be unbalanced chromosomes in the egg and sperm, and so that can result in multiple miscarriages. So we'll check their genetics. We check the anatomy of the uterus, sometimes septums, fibroids, polyps, these type of things can be related to miscarriage. There's a condition called an autoimmune condition called antiphospholipid syndrome. And we look for antibodies in that patient to sometimes they're at more risk for blood clots. Maybe that's contributing to the miscarriages. And so in that patient, we would recommend blood thinners like heparin and baby aspirin. Endocrine is the other issue that can occur with recurrent pregnancy loss. So making sure there's no uncontrolled thyroid disease, uncontrolled diabetes, uncontrolled prolactin. So these are the typical things we look for in a recurrent pregnancy loss workup.
Thank you. Okay, I have one last question. It's a great question, and then I will close out. But remember, everyone, if your question didn't get answered, please reach out via Instagram, DM us. We are in touch with all the doctors. We'll be able to get your questions answered. And that's what we're here for. So please do so. And then remember, the promo code is JUL22. When you go onto the Kindbody website and you book a new patient appointment, you can put that code in, and it will save you $100 off your first appointment. And then going further, if you're going to book a cycle, you can give the person, we book cycles on the phone. So when you speak to someone, you can give them that promo code and they will apply that discount for you. So very exciting. And we will be sharing that by email tomorrow. So in summation, one last question, can you do egg freezing and embryo freezing simultaneously?
You could. So the counseling would be different just depending on the woman in terms of her age and her ovarian reserve results. So, if a woman has a high follicle count, then yeah, you could, like, let's say she has 20 eggs that are retrieved. So you could theoretically freeze 10 eggs and then create 10 or take the other 10 eggs to try and create embryos. The thing to keep in mind is that those 10 eggs that we use to create the embryos, there's going to be a decline in numbers as you go through the process. It's just normal going through the IVF process. So of those 10 eggs, not all of the 10 may be mature, not all of the 10 may fertilize, and not all of the 10 may make it to that blastocyst stage. So it could be that, of the 10, maybe, we end up with 2 embryos, let's say at the end, and one's genetically normal. So that's kind of the decline in numbers that are normal to anticipate. So, but let's say another woman has a lower follicle count starting off, then, it may, it may not make sense depending on the patient and depending on the number. So definitely talk about it with your fertility specialist. Another option is you could do one cycle where you freeze eggs and then do another cycle where you freeze embryos. So that's another option. So it's just a bit of a numbers game. So it's good to have an understanding of expectations if you're considering splitting things, because then you're kind of losing numbers in that way by going down 2 different paths. But it's definitely an option.
Okay, thank you so much, Dr. Kathiresan. Everyone's thanking you. This is the best. Everyone wants to get their questions answered from you. That Instagram, everybody hops on those AMAs all the time. So this is really a treat for us. Thank you so, so much. And please, again, if anyone didn't get their questions answered, reach out on Instagram, and we'll even get Dr. Kathiresan to answer them for you.
Sounds good. Thank you, guys. It's always great to hear that it was helpful. So I'm glad it was helpful. Thanks for having me.
Thank you all.
Bye.